So thanks for the opportunity to speak today, and I'll be talking a little bit about interdisciplinary team training and tips and tricks. I have no disclosures. So there's no doubt that effective teamwork and communication skills are required for high-performing providers across healthcare. And I think this is most important in the operating room, where it's riskier and where things are more stressful. And the model that we have in Boston and in Massachusetts is unique, where our medical malpractice insurance company, Crico, has actually partnered with the hospitals to help fund a lot of interdisciplinary team training programs. So as we're all aware, malpractice claims are really only the tip of the iceberg of adverse events that occur in our healthcare systems. And when Crico performed a claims analysis, they found that medical errors resulting in preventable patient harm was due to usually one of two things: technical errors and communication breakdowns. And in fact, they found that with deeper analysis that while surgical technique matters, it's the response or the lack of response to a technical error due to poor communication that often results in patient injury. So faulty teamwork or poor communication can lead to any one of numerous issues, such as wrong site surgery, retained foreign bodies, a failure to communicate change in vital signs, failure to rescue in the operating room, nurses being afraid to speak up, or when the safety checklist is not taken seriously, potential safety issues can also be missed. So in light of all of this data, Crico funded a pilot team training project in 2010 across the 4 main Harvard hospitals to develop a standardized interdisciplinary OR team training program, which they felt would improve communication, increase teamwork building skills, and also improve patient safety. And so they also offered a 10% malpractice premium reduction for all surgeon participants. And the results of this pilot were overwhelmingly positive, to the point where most participants felt that this program should be rolled out across all of the Harvard hospitals and incorporate more surgical subspecialties. So the next phase, Crico funded a 3-year program where they looked at, where they offered the multidisciplinary team training grant across all of the Harvard hospitals. And the participants were participants who were high risk as based on historically closed claims. And so these are the groups: cardiac surgery, general surgery, gynecology, neurosurge, ortho, otolaryngology, and thoracic surgery. So at the MGH, we were lucky in that we had a huge amount of leadership buy-in, and it was felt that of our 150 or so eligible surgeons, this should be a mandatory exercise. We ran our program from March 2014 to October 2017. Again, a 10% rebate was offered to participating surgeons in their malpractice premiums. On average, we ran about 2 sessions per month, each running about 6 hours, where we covered 3 different interdisciplinary scenarios, and this time also included breaks, snacks, lunch, etc. In total, we completed 58 sessions. And when determining which non-technical skills to focus on, we really looked at the historical closed claim studies. We looked at the interests of our stakeholders. We also looked at kind of what our learners were interested in improving within each of the institutions. And we came upon these following non-technical skills: use of the WHO OR checklist, speaking up, closed loop communication, role clarity, and early mobilization of resources. We're lucky to have a large core group of interdisciplinary faculty, and this is really critical, and I'll touch upon it in a second, on developing relevant scenarios as well as for debriefing. In total, we had 327 participants, with 109 of them being the surgeons. And if you broke that down, these are each of the specialties and the number of surgeons who went through our program. All in all, across 11 different institutions, 545 surgeons were trained. And overall, this was a very successful program with over 97% of participants rating it as above average to excellent, and over 87% of participants feeling that they improved their communication skills afterwards. But certainly there are potential barriers that each of our institutions had to address. This includes cultural differences between professions, a lot of logistical challenges and scheduling, financial support for the program within each of the institutions, as well as the amount of cross-trained faculty, which varied across the hospitals. And so based on kind of the work that we've done and the lessons that we've learned, I've come up with 6 tips and tricks to successfully build an interdisciplinary team training program at your institutions or at any institution. So the first is to focus on interdisciplinary. And so you want to ensure that your learning objectives focus on interdisciplinary knowledge, skills, and attitudes, such as collaborative teamwork and communication. There are plenty of interprofessional competency frameworks that can help guide learning. And ideally, you want to use the simulation setting to enhance experiential learning, to deepen the understanding of each of the participants' roles in the operating room, and give them an opportunity to practice coordinated decision-making. And finally, you want to balance the mix of participants so that it most closely resembles the group that's working in the operating room. Second, you want to know and work with your audience. And so you want to identify and engage the key stakeholders at your institution. This is not only getting buy-in from institutional leadership, but also realizing which learners would benefit the most from your program and targeting them. And you also want to work within the culture of your institution. And by taking those first 3 things, it makes getting past a lot of the barriers, such as funding, finding time to participate, making this a mandatory activity, or giving participants protected time. It makes overcoming those barriers much more easy. You also want to consider collaboration with groups that have a similar mission as yours so that you work synergistically, such as your hospital QA committees or your medical malpractice insurance company. And this might give you an opportunity to offer incentives to participants, which is also always helpful. And as you're developing your program, you want to continually educate and inform not only the key decision makers, but also the participants as well. Number 3, you want to identify simulation champions, and ideally you need champions from every profession that is participating in your program. This minimizes concerns about inequalities of authority and status, and it also reduces potential resistance from the various learner groups. A strong interdisciplinary core faculty is also essential. This helps with high-fidelity curriculum design. It helps with recruitment of participants, with getting feedback about how your program's running and ways to improve it. And having different simulation champions within each department also helps engage the managers, administrators, and other colleagues in those departments. And finally, you want to expand and grow, as well as to maintain your simulation champion pool, and this is through Train the Trainers courses as well as faculty development. Number 4, you want to develop scenarios that are relevant to all of the professions that are participating in your simulation curriculum. Ideally, each profession should have a significant and balanced role. Your scenarios should be high fidelity, relevant, and socially realistic, and that means that in any operating room, there are naturally some hierarchies and some difference in status between the different role groups, and so you want to make your simulations as realistic as possible. You may also want to consider hybrid simulation, and so this video that's on loop right now is a model that a bleeding tumor model that we made. So in each of our simulations, for example, the surgeons would be focusing on this, while the mannequin was having hypotension, tachycardia, so the anesthesiologists were working on that. And then we would have an open OR tray with instruments that were contaminated that the nurses and scrub techs would be working on. So everybody was involved and it was realistic. Number 5, maintain a safe simulation space. So this is pretty basic of any simulation. Establish clear ground rules and review the basic assumption that everyone comes here with the best intentions and is willing to learn and improve from one another. Acknowledge potential interdisciplinary dynamics. The quality of your debriefing is really what people will score your, or look, or have evaluate your simulation. So that is really key. You want to maintain emotional and psychological safety for all of your participants and allow them to express their individual points of view, but also moving forward that the whole team agrees on a plan for each of the scenarios. And you want to consider the use of co-debriefers so that when you're debriefing, you don't just have a surgeon debriefing, but you also have nurses and anesthesiologists as part of that process. Finally, you want to base any assessment on your simulation scenarios on the team performance rather than individual performance. And so there are multiple validated instruments that are available for you to use. So these are the summary on tips and tricks. And the other one last advice that I would give is to start small. So you want to start with a group where you can develop a solid program and show that you're successful and get good buy-in from your participants and build on that to expand your program across your hospital. Thank you.
Thank you. I'd like to invite